Recording. All right, so yeah, it's been a while since we've met up since December. Yeah, we missed most of January. So we'll get right back into the swing of things with how to succeed as a reviewer here. And what I'm trying to find is where's my screen? Um, okay, yeah, here we go. All right, so I got my screen. All right, so OASIS E. So what have we learned so far? Because, initially there's been a lot coming in, on different days. I'll throw something out. Hey, this is what we hear now. And of course, then the Q&As hit mid-month. And along with all that, I know I had peppered the CMS help desk with a lot of questions about E, just as they were coming in from you guys. And then as I was getting answers out from them, I was trying to, roll them out as well, anticipating that they would not show up in the Q&As, as they did not do. Sometimes they will, but for the most part, they generally will not hit the Q&As for whatever reason. I think they need to wait to see if they get a lot of that same question, then it'll pop up as a Q&A, but otherwise they just keep answering me. Sometimes with good answers, sometimes I'm like, seriously, that was really not an answer. You're throwing guidance back in my face. But regardless, we've had some new stuff that has come through. We just want to make sure everyone is on the same page with looking at that quote unquote new stuff. So one of them was regarding the pain items. And, anyone that was involved in, all the prior OASIS versions, pain was always, kind of a pain to answer that question because there was no clear guidance as to, what's the time frame you're looking at? It was always the recent pertinent past, which is just as gray as you can possibly get. And, we really like things a little more black and white. So I was happy when they came out with these pain items, J, 5, 10, 20, and 30, and that we actually now have a look back. And the look back is 5 days. So the question came in, okay, so what is considered 5 days? So it is always, anytime we are looking back on something, a look back item, the past 14 days, past 2 days, whatever it might be, the day of assessment is always your day 0. And then you count back, in this case, 5 days. So I put that little chart up there, a little calendar that says whether you're on the start of care or you're doing a resumption of care or your discharge visit. Today is day 0. And then you count back 5 days. Before that 5th day, we don't care. We don't care if you were in 10 out of 10 screaming pain and you went to the ER. We don't care. We're just asking about the previous 5 days is all that's looking for in that item. Okay, so day of assessment is always day 0 and you go backwards. And K0520, the nutritional approaches, some questions have come through about that regarding like the therapeutic diet. It gives the, for instance, low salt, diabetic, or low cholesterol. So of course, anytime there's a, for instance, or for example, we're allowed to expand further into what seems similar, as opposed to what it says specifically, you can only consider what's in the parentheses. For example, your mind can expand. So with this, a heart healthy diet, and you see that on a lot of cardiac patients, it'll say heart healthy. That is a therapeutic diet in and of itself. It'll consist of a lot of things like no salt, low salt, this, that, and everything else, but heart healthy is a therapeutic diet. Someone doesn't eat anything with peanuts because they have a peanut allergy. That is a therapeutic diet. Again, no added salt, low salt. All of these constitute that. So it is the kind of thing that is really doesn't have anything strictly set, but there has to be a rhyme or reason for it. A question came through. I think this actually came from one of our people, and asked me. I'm like, I have no idea. So I sent it in. They came back with actually a good response here. And the question was, a patient with signs of dysphagia is ordered by the provider to be on a regular diet, but to take their pills, the food is to be pureed and you mix the pills in. Kind of like what you have to do with toddlers and dogs, right? Kind of mix the pills in there. Don't look in the applesauce too closely. And they wanted to know, is this considered a mechanically altered diet for this item? And basically what CMS said was that mechanically altered diet is defined as one obviously specifically prepared to alter the texture or consistency of the food to facilitate oral intake. If you're doing it for some other reason, then it's really not considered a mechanically altered diet. So if it's not for nutritional purpose, so in this case, they're mixing up the food so they can hide the meds. That is not a nutritional purpose. That is to merely hide the meds and make it go down easier, right? So it would not be considered a mechanically altered diet just because you're pulverizing the food and mixing the meds in. The one that gets and probably will continue to get a lot of play until they totally do something about this, or I don't know, take a bomb to it and try again. N0415, the high risk drug classes item. So we know column 1 is that they are taking something from this high risk drug class. And we know it's in that drug class because when you look it up on Dr. Google, either go to the NIH site or whatever it is, maybe the EMR has the classes printed up. We see that such drug is in one of these classes. All right, so that's the easy one. They have the med, they're taking it. The hard one comes in, is there an indication noted for it? And we've had, some more information come on that as to how to determine, is there an indication noted? So of course, the easy ones. Is there something in the chart that says it? Did the clinician call a provider and verify that the patient's taking the medication for whatever reason it might be? Just as long as there is a reason that they're taking the medication, regardless of its drug class. So what that means is, let's say the provider says to take an antipsychotic as a peripheral nerve relaxer. You would still have, the clinician should have checked off boxes. 1, obviously they are taking it. And 2, there is an indication for them to be taking it. It doesn't mean that there's an indication for them to be taking it as an antipsychotic. It just means that, yes, it is okay for you to consume that medication. I gave you a good reason for it, so you should be taking it. Okay. Aspirin has been getting a lot of play because I don't know, I might have said something in December. I don't remember anything I said yesterday. But aspirin can be taken as an anticoagulant, but it is not an anticoagulant. Aspirin, along with being an NSAID, is its primary drug class, is an antiplatelet medication, has a secondary drug class to it. So aspirin would be marked off on row I, antiplatelet. Even though it might be functioning as an anticoagulant, it is not an anticoagulant. It is an antiplatelet. And those two drug classes can sometimes get muddied. I know it's a lovely cough. All right. One of the other things that had come up with this is people trying to equate N0415 to M2010, which is our high-risk drug education item. All right, so I know we're talking about high-risk drug classes here, and we're talking about high-risk drug education. It makes sense that you're going to think, well, are we not talking about the exact same stuff? Not really. For M2010, you want to be sure that you're always following whatever agency it is that you're working on, follow their policy of what they consider to be a high-risk drug. They should have their list of, this is what we consider high-risk drugs. For N0415, the drug classes are determined by the NIH. All right, so you might have some things that the agency considers to be a high-risk drug for M2010. I'm sorry, that let me try this again. Patients can have a high-risk drug class medication that the agency does not consider to be a high-risk drug for M2010. I cannot think of one off the top of my head because I really cannot think off the top of my head right now, but I'm just saying that these two don't necessarily go hand in hand. All right, there could be a discrepancy, and that's okay. For the Q&As, indication, right? That column 2 can be by any method. The medical records, right? Do you see something in there for why they're taking a medication? The med list, discussions with the provider, the staff, the patient's family. What the patient or the family told the clinician has to be supported in the medical record, or by the provider in some way. So that clinician, they can get that information from the family, but they really should have it verified. So for instance, the record says the patient had total knee. You see they have a script for the oxycodone. Patient says it's for the knee pain. That makes sense, right? 2 and 2 is equaling 4. They have total knee, they have knee pain, they have oxycodone, which is for pain. It's an opioid. Great. I have no problem with that. But what if you see that they have Ozempic in the home? There's no indication of diabetes in the chart. Patient, ask the patient why they're taking it. They say for weight loss, because we know people are losing weight taking Ozempic, right? Looking through the record again, we cannot find any indication of there being a weight issue, right? You would expect to see obesity, morbid obesity, just something, right? Can't find anything for that either. The clinician should not have marked J2 until this method is verified with the provider. So even though the patient is telling them that, they really should verify that, because that's one of those things that, are they really taking, should they be taking this? Are they taking someone else's medication, right? And we know sometimes, people get their hands on other people's medications. Why do you have that, OxyContin? Where'd you get that from? And they're like, yeah, don't ask that question. Like, okay, that would be indication not noted, when they won't answer you where they got that medication from, but they're taking it. So this is just one of those, is there logic going on to what's going on? And unfortunately, we're on the backside of this. We don't see a lot of that conversation going on, but, can we see, at least in documentation, does something make sense? And, if it doesn't make sense, I'll just query it. Just put a note, hey, just to verify that. We've seen this slide before. The only thing new on this is, I asked, someone asked about heparin flushes, and per the CMS help desk, they don't consider flushes to keep an IV access port patent. So that would be coming in on the anticoagulant side in particular. It's not to be considered an anticoagulant, the heparin flush. Just flushes keep a port patent, not considered a medication.
I'm sure you did. You're good at that. So praying that.
All right.
Can someone mute themselves? All right.
Thank you.
00110, the special treatments, procedures, and programs, our favorite item. A lot of questions coming in about chemotherapy. Just remember, these agents are chemotherapy medications administered for cancer treatment. Okay, if they're getting chemotherapy agents for something else, it's not to be counted here. It's only if they're getting it for the treatment of cancer. The oxygen therapies, I've seen some interesting things where clinicians have just totally blew past this whole oxygen section, and yet someone is taking oxygen. It's like, okay, you have 2 liters per minute via nasal cannula at night, and there's nothing checked from this section, just whoosh, whiffed right past it. And you know what? So did the reviewers. So just remember, if you're, checking, you've done the coding and you coded oxygen, immediately run to this item and see, did they check off, the C1 and then the appropriate C2, 3, C3, or C4 for those. And we do have, the limit set on these where continuous is greater than or equal to 14 hours a day. Now, I don't know if we're ever going to see documentation like that, but just continuous does not mean 24/7 for this item. Intermittent is more like what you would consider your PRN. But again, are we getting how many hours intermittently actually adds up to? Because what we might consider intermittent might actually be considered continuous if it's more than 14 hours a day. And then C4 is your greater than 4 liters via nasal cannula. And again, you could have C4 and a C2 or 3, depending on how often. If they are getting more than 4 hours, it is probably continuous, because that's looking for a lot of oxygen therapy. The mechanical vent, the question came through. Does a CPAP or BiPAP actually deliver oxygen? And so I looked that up. So that's a good question. My mom's out of CPAP. I should know that. So these units deliver room air, which is oxygen and nitrogen plus other elements. They do not deliver oxygen via a concentrator, which is pure oxygen, but they can have an oxygen concentrator or tanks connected via an adapter. And if so, you would also answer those C items for the oxygen, as well as these BiPAP or CPAP items should be answered. So it all depends on what's actually going on in the home. Generally, the CPAPs and BiPAPs are only going to be answered with these G items. I can't think of all the time when I was in the field, all those years, of ever seeing a CPAP or a BiPAP hooked up to oxygen. But I hear it can happen, but I personally never saw it. This is just, again, just a little wrap up of, M1400. How is their, how's their stamina? Are they using oxygen? Are they getting short of breath on it? And what are all those limits? And then we had finally stuff come in regarding discharge without a visit. And I felt the need to write into CMS based on something else I had seen posted on a Facebook site that I did not agree with. So I wrote in. And basically, I was just asking if an assessment, if you're trying to do a discharge OASIS without a visit, so, someone has either flown the coop or they just will not let you back in. So you're basically, doing this, on the fly based on information, what information can we do? Because there are some items now in the OASIS, particularly the E items, that do not allow a dash as a valid response. It's just not one of the responses you can choose. So it's like, okay, how do you answer those? If you can't ask the patient because they're self-assessment items, because the patient is not there, how do you answer them? So the first step is when you're, especially those of you now working through these discharges and you see these, that it's a discharge without a visit, the first step is always to look, was an assessment addressing the OASIS item in question performed in the last 5 days? So again, today you're looking at it as day 0, count back to 5 days, and you're allowed to look through any visit notes from any discipline to see if any of those questions might have been asked during those visits, that you'd be able to come up with an answer on this. It doesn't have to be just the nurse. Did the OT ask? Did the PT ask? Did the home health aide ask? Was MSW in there in the last 5 days? And if they did ask that question, that will lead you to be able to answer that particular item, then you can use that information. We're allowed to use that, that last 5 days in there. And if no one did ask any of those questions, then we can use a dash if it is allowed in the item. But if a dash is not a valid response, right, if it doesn't exist for that item, CMS said if the patient is unable to respond due to an unplanned discharge and it's allowable, and that's per the code set, use either the X or the 8, which is patient unable to respond, depending on the item. So you're going to have that choice of X or the choice of 8. So whichever is most appropriate, there's your out for how do we code that item for a discharge OASIS without a visit. All right, so that was all the slides I had of what we're seeing up to date right now. Bark at you a little bit here. Does anybody have any questions?
Hi there, this is Janice.
Hi, Janice.
How you doing?
Good. It's Ducky.
Good. There's some questions that came through.
Yeah, I just pulled up the chat. Yeah. Ice-mageddon. Yeah, absolutely, Callie. Yeah. Do we take the word of the clinician if they checks the box for indication noted? Unfortunately, it's by conversation. Yeah, I know. All right, so the question is, do we take the word of the clinician if they check the box for indication noted? Asking because one of the ways they can find out an indication is by conversation, yes. Or do we direct them to document the indication when doing QA? If we cannot find in the record that there's any rhyme or reason for why someone is taking something, but they have checked that an indication is noted, I would just have a blanket note that says, please document how, how I'm just going to really be bad with thoughts here because my head is still stuffed with crap, but please document, how that information came about. Where did you get it from? Where is it verified? If you call the provider, there really needs to be that documented for sure. But they should just have that documentation of where their source. That's the word I'm looking for. Document their source.
I have another question, if that's okay.
Yeah.
I thought I saw something about the guidance for this item to include if something was patient specific for N0415.
Not sure what that
would be
means.
considered an indication.
Patient
I'll have
specific.
to look for it. And,
yeah. Hit me up on that one.
Okay.
Julie Taylor, oral antibiotics. What's your question?
That was in response to one of the medication questions, and she threw that out as an example.
Okay, thank you. Do they need to have the chemo agent listed or noted somewhere in the visit to check for chemotherapy? Okay, so here's what we're running into now. In October, we got a whole bunch of new meds codes. The Z96.6 is all those chemo codes in anticipation of what was going to happen with OASIS E. So I just use the colloquial, they are anticipating that we're going to be coding these chemotherapy drugs as well, which is like, has anyone ever seen them actually listed out? Every now and then you might. If the chemo agents are listed in the H&P and they put it on the med profile, we should be coding them, and then we can be, obviously, we see that the chemo agents exist and they should have been checked off for the appropriate item. So, yeah, someone had to have known there was a chemo agent for some reason in order to first check that box that there's an indication for it and that they're taking it. Not the indication, but just that they're checking it in that O box. That is a chemo for an anti-neoplastic treatment. But the thought process is that they really should start infiltrating the documentation, and we should be able to start seeing those chemo drugs coming in and start coding those as well. Whereas in the past, they've always just been a thought because it was something that was happening outside the home and we didn't care. Well, unfortunately, now we have to care. For antibiotic, does it include items such as ointment? No. It's oral IV injected. Do we mark high-risk meds if they are prescribed and should be taking, but they are refusing to take? Yes. We always mark everything. Nothing in the OASIS is based on compliance. It's always what they're supposed to be doing. So just because someone is non-compliant, we still mark them, just like, the basic M1033. How many meds do they have? Are they taking 5 more meds? They can have 10 prescribed and refuse to pick up the scripts on any of them. We're still going to say that they have 10 prescribed meds. So yes, we still have to do that. Let me roll up. Oh, got that one. Pain section. Hey. Clinician says patient did not have rehab visits in the past 5 days, but we know they did per chart review. It must have been a meaningful visit. Do we change the answer per the note we get that information from? Yeah, it could be someone did not understand what was meant by rehab visits. Rehab visits does not have to be a formal therapy visit. It could just be, it could just be that their granddaughter is coming over to the house and making grandma do her exercises twice a day. That's a rehab visit. So it's just it's a therapeutic visit. It does not have to be a formalized therapeutic person. So that could be where that confusion is still coming in regarding those items. So yeah, we change the information based on what it's actually supposed to be, and hopefully they'll learn eventually. That's just one of those tougher things. We knew as soon as that item came out that was going to be an issue. Is there a guide for coding chemo meds? I have a hard time figuring out the correct code. Yeah. It's going to start with the Z796. That's the best I can give you. I mean, I had, I sent that primer out with the chemo. Maybe not. No, that was on meds. Yeah, it was just the second sheet with just like the different meds listed, but not every single medication out there. But they're all, starting the Z97, Z796, you'll probably run into what you need. But everything, finding meds always starts with long-term, current use of, administration of. Are hormone therapy drugs for prostate cancer or breast cancer, for example, considered chemo meds? You'd have to look them up. I'm not going to answer that one. Anytime when it comes to figuring out what a medication is, I'll go to Dr. Google, look it up, see what it's drug. I'll just type in the name drug class and see what it says it is. For 0110, are they only treatments in the home? Nope. Anything that happens to you, regardless of the setting, and that's one of the changes that came to us with OASIS E is before our heads were in the sand. We only looked at the patient and what happened to them in the home. Now we have to look at everything that happens to them in every single setting and account for it. So yeah, these are for regardless of where, if they're going out for chemo, they're going out for dialysis, they're going out for anything, we're still counting it in the OASIS because it is happening to the patient. N0415, does the provider need to specify the indication for the medication, or does it just need to have a diagnosis documented that would be treated for that medication? I think if you have, a diagnosis that makes logical sense. Like I said, can 2 + 2 = 4, or is 2 + 2 = 5? Why do you have this medication, right? If you can't find any reason for it, then I'd be questioning that. But if you see that someone has such medication, that's a hypertensive med, they have hypertension, it's all good. I think the clinicians are probably allowing some loosey-goosey on there as well. For J520, that's pain. You would still need to find the documentation, not only that they had therapy in the 5 days, but that the pain limited their participation in therapy. Yes, to find out, yeah. And how did they do with that? Did you have therapy in the past 5 days? And if so, was there any issues with pain in that? Yes, good point, Kelly. Some of the breast cancer meds have specific non-chemo codes. Okay, I'll take your word for that, whatever that is. For the pain items, since these are patient interview questions, we can't comment to change, but to review for accuracy of the response based on response appearing to conflict with pain assessment, having therapy, etc. Yes, we can always comment that something doesn't quite doesn't line up right. A patient can say, yeah, it really didn't affect me much of the time, but hey, they refuse therapy every single day. Why? So yeah, if something just doesn't add up, you always question that. There's nothing wrong with that. You can question the entire OASIS. What the clinician chooses to do back on their side when they get your comments back is entirely up to them. But our job is just to stimulate their thinking, to make sure that they have the most accurate response within the body of the OASIS to really capture the way this patient truly is. Because, if you have someone, at that start of care at such a high level saying, oh, they're just wonderful, they're just, everything is roses and, daisies and everything, how the heck are you going to improve on them? And by the way, what are you doing out there with them for the next 8 weeks if they're all fine? So, there's clearly something not right then in your responses, because you're not giving yourself any room to improve on something you said is not a problem. But yeah, we're going to spend out the next 8 weeks out here improving on something that I said was not a problem, which doesn't make sense. So it's all about getting that correct assessment in there and really scoring them appropriately. On the DC side, I'm seeing a 0 for 520 at start of care, and then at DC they have had pain, and now it looks like pain got worse at DC. Yeah, well, that's and some of that actually can be their medications ran out. So now they're actually feeling pain, whereas before pain was not bothering them at all. And that is a problem, especially with joint replacements. You go from being on really good meds to not so much really good meds by the time you're discharged. So you are now starting to feel pain, and it happens. But again, let's get that more accurate response up front and make sure if someone says 0, I'm not feeling any pain, that really, are they not feeling pain? Is pain really not interfering with them? I mean, then why are you using an assisted device? Why do you need help to do this and this and this? You're feeling pain. Avoidance of an activity is pain interfering with activity. Using an assistive device is because of pain. If you didn't have that assistive device and you put all your weight down on, both those little limbs, and now you're feeling pain, okay, you've got pain. So, you've just had a tool to help avoid that pain. So it's just a matter of getting that kind of Yoda way of thinking around to the clinicians of, it's again still about pain interfering with something, to answer those correctly. Yeah, I don't know about Megace. I've seen a few zeros at discharge. We just love zeros at discharge. They're so easy to just answer. Or the nerve block wore off after surgery. Oh, Holly, you and me, we know about nerve blocks wearing off, don't we? I can tell you exactly when mine wore off, when I had my ACL reconstruction done. It's at 8:17 on a Friday night. No doubt about it. That's exactly when it wore off, because all of a sudden it was like instant, holy crap, my leg is being ripped off my body. All right.
Those things always happen when the weekend starts.
Oh, I tell you,
Never.
man. Well, that's when I found my bottle of Percocet. I was doing really good right up to the point. Didn't need my meds. Oh, there's nothing to this. Then the nerve block wore off. That's when I discovered the Percocet. Spent the next 3 days in a drug-induced haze. It was wonderful. All right. Any other questions? Looks like we hit them all.
I have a non-related question, and it's regarding all these new dementia codes.
Oh,
and I
okay.
understand, like, if they have, and hopefully it's okay to do it now. So say they have dementia, and they also have depression, and they have anxiety, whether it's specified or moderate. I mean, I understand all that, but would you code like I think it's,
Link them all.
so you link them all, but
Link 'em
would you
all.
code the dementia twice, or would you do the one with the?
No, you would have the FO393 and the FO3818, whatever they are, whatever that extension is, to indicate that disorder that comes along with it. So you have the dementia with the behavioral disturbance indicating the depression, and the dementia with the disturbance indicating the anxiety. Those are 2 different codes.
Okay. So do you put both of those codes down? So like FO 3.93 is the unspecified dementia, unspecified severity with the mood disturbance. Then would you put the depression F32A under that?
Yeah.
Okay. But with
Yeah.
the anxiety one, because
The
you know
anxiety
they already
is
have
already
the anxiety.
part of the dementia anxiety code. I would only include, if it's just anxiety unspecified, that's already part of that FO3 point, whatever it is.
Right.
If they have a specific type of anxiety, then I would also include that F41, whatever it is, code for that specific type of anxiety. But just general anxiety, it's already there in the code.
Okay, so if they had the depression, the anxiety, and the dementia, you would code the FO393, and then add the depression to show that, and then the FO3.94 to show the dementia with the anxiety.
Absolutely.
Okay. Yep. I wasn't certain if that dementia got coded twice, or you just put like what it is after, and that's how I started doing it when you sent that the other day. It's kind of
coded twice, but it's not coded twice in that, you're not repeating a code.
Okay.
I always look at it like we code. I always look at it like we code diabetes complications, and you might have 3 or 4 diabetes codes.
Right. It all comes down to, what happens after the decimal point. Yeah.
Good point. Thank you, Arlen. Thank
Yeah,
you
as
very
long as
much,
what's
April.
after the decimal point is different, you're not repeating anything.
Okay, okay.
Yeah.
Thank
That's
you
a
for
good
that
analogy there,
clarification.
April. I like that.
You know, I'm a keep it simple, stupid person. That's how I remember stuff. So.
Yeah. Elizabeth says,
That's a
don't we
good
need
point.
the MD statement that the anxiety or depression is linked to dementia? Nope. If we can find it under the with, we can go ahead and link them up. And that's, basically been the, we've had some jokes at time going around with, the Oprah, you get a link. And that's really, anytime I send a question in to not to CMS, to the coding center on this dementia stuff, they keep coming back saying, yeah, you can find it under the with. I'm like, truly, if you find it under the with, then go ahead and link it. We've got nothing that says we can't, which is just interesting. Okay. Good questions, guys. I'm good. Stop the recording, which I hope I had started. Stop recording, yes. All right.